afternoon and a very warm welcome on behalf of the European Health Forum and MSD, which has organised this session, to this discussion on action on HIV for a resilient Europe. Can a shift in policy halt the burden of this epidemic? My name is Jackie Davis. I will have the privilege of moderating this entirely interactive session. If you want to ask a question of our distinguished speakers, please use the Q&A tab at the bottom of your screen. And could you be as brief as possible so that I can see at a glance what your question is and who it is for. So that's the Q&A box. If you want to exchange views with other panelists, with each other, please use the chat box. And one important note, if you scroll down the drop-down menu to all panelists and attendees so that you can speak to everyone, please do feel free to use the chat box for that. And if you'd like to tweet about what you are hearing at this event, the Twitter hashtag for Gastein is hashtag EHFG2021. So it is, of course, 40 years since the start of the epidemic, and significant progress has been made in controlling HIV. But much more remains to be done in order to meet the United Nations 2030 target, Sustainable Development Goal 3 on healthy lives, which sets that goal of ending HIV/AIDS epidemic as a public health threat by the end of this decade. And indeed, in June, the United Nations warned that these ambitious goals to stem the spread of HIV and widen access to treatment had been missed, and they were jeopardizing the chances of meeting them by 2030 unless global efforts were stepped up. Time is running out, they said. So what we want to discuss this afternoon, are existing approaches adequate to meet the challenge, or do we need a significant shift in policy? What role can and should governments and policymakers play now in refocusing efforts on HIV and ensuring it's a priority in Europe and across the globe? And why is it more important than ever for them to do so in order to ensure health systems are set up and policies evolve to meet the changing and unmet needs of people living with HIV? And finally, can HIV act as a model for disease prevention efforts in other areas and thus help in meeting the broader objectives of SDG 3? So joining me shortly to discuss this will be Dr. Tamas Beretsky, who is a patient advocate and he's a consultant at Patientcentered. Dr. Cristiana Oprea, Associate Professor at the Carol Davila University of Medicine and Pharmacy and Head of the HIV Department at Victor Babe's Clinical Hospital for Infectious and Tropical Diseases in Bucharest, Romania. And last but not least, John Ryan, Director of Public Health in the European Commission's Directorate General for Health and Food Safety, better known in Brussels circles as DG Sante. But before I have a chat with them, I wanted to get a snapshot of your views to feed into our discussion. So in order to do this, I only have one question for you, and I'm going to give you plenty of time to answer it. But let's have a look at that question. And in order to answer it, you can go to slido.com. You will see a link appearing in the chat box. You can click straight through, or you can use the QR code on your mobile device or the website code in order to get in. As I say, you'll have plenty of time to answer this because we're going to come back to it later on. So our question, we are asking you to indicate the top 3 elements that you think are most important for a successful strategy to sustain healthy outcomes for people living with or at risk of HIV. Is it for you, and as I say, you can pick up to 3, investing in innovation in both treatment and prevention? Is it prioritizing HIV prevention? Is it access to medicines, diagnostics, and viral load tests? Combating stigma and discrimination? Or supporting patient communities and NGOs? I'm sure you will say all of the above, but of those 5, if you could pick 3, just so we get a sense of your priorities, and I'll be asking our panel for their priorities and what they believe are the key elements of effective strategies to really accelerate progress now and meet those targets 30. So as I say, we're going to come back and get the results of those after I've had a little chat one-on-one with each of our speakers, and then I'm going to bring them all together for a discussion between each other, and at that point take also any questions that you might have. As I say, Q&A tab if you want to join the conversation. So Tamas Beretsky, if you could activate your camera and mic. Hello, very warm welcome. Thank you for being with us.
Hello.
Tamas, just let's start with where the challenge is. As a patient advocate, what are the main challenges facing people right now who are living with HIV in terms of equal access to innovative treatments, prevention strategies? What is the situation as it stands?
I think that the biggest, first of all, thank you very much for having me. And it's a true pleasure. I think it's tremendously important that we keep HIV on the agenda, not just for us, people living with HIV, but also for the broader communities throughout Europe. I think that the biggest challenge is, and this will not come as a surprise, I suppose, the biggest challenge is this huge shift of attention away from HIV in particular, but also other communicable diseases except for COVID, which has left us in a very sad place, because actually everything that's been happening in COVID was and could have been predicted on the basis of what happened in HIV 30 years ago. And so I hate to say this, but we told you so. So when the first signals came that people living in poorer conditions or populations that are left behind are more exposed to COVID, that's the same pattern that we saw 30 years ago in the United States, but also in Europe with HIV. It's the same. So the social collaterals are very similar in terms of COVID and HIV. And yet there was this partly understandable shift away from everything else and towards COVID, which left patient organizations short of funding and resources, which left patients exposed to yet another load of stigma and discrimination. Once again, this age-old thing that we find in the literature in health sociology, that illnesses, especially communicable diseases, are stigmatizing, that was confirmed again. If you look at what happened in Canada, where people had to leave their homes because they were discovered to be living with COVID and they were seen as vectors of disease. We've had that in HIV as well, but that again, steered people's attention to the risk of contagiousness.
Is there not more understanding now than 40 years ago? I mean, it sounds as if you're saying the situation isn't much better than it was when the epidemic first became known about and so on. Is the stigma, the discrimination still as bad?
It is, yes, I'm afraid. It's, even though there has been a lot of work by patient constituencies and organizations, and some of this work has been tremendously successful, like the U equals U initiative and plenty of others too. These are really brilliant projects that have brought so much, yet it's still there. I mean, there seems to be such a low level of health literacy in many places, also in Europe, also in some of the developed countries, which has surfaced now with the COVID epidemic, right? So right now that we see all this anti-science movement, the skepticism, that's what this lack of knowledge, this lack of awareness is what fuels stigma.
So we had an existing challenge to address those issues now made so much more difficult by COVID. But let's, in our discussion later, look forward. Let's look to what we can do to address some of those issues and make sure that COVID doesn't result in us going dramatically backwards on the achievements that we have made that I spoke about at the beginning. Tamas, we'll talk to you again shortly. Thank you very much for now. Dr. Cristiana Oprea, if you could activate your camera and mic. Hello again. And as I say, you are an associate professor, you're head of an HIV department at the Clinical Hospital for Infectious and Tropical Diseases in Bucharest. From your perspective, and we heard there about some of the big challenges that still face people living with or at risk of HIV, in terms of key unmet needs that still need to be addressed if we're going to meet those targets, what are they for you, Cristiana?
I wish to start first with what was disrupted during the COVID pandemic, because there were a lot of disruptions in HIV testing services. There were a decline in the number of people that initiated HIV treatment. So this has a negative impact on the first 90 of the HIV cascade of care. And of course, the coverage of HIV prevention programs, at least among key population, PrEP, condoms, that was a lot of delay in these programs. Also related to HIV viral monitoring and resistant testing in this period. STI testing services were disrupted. Hepatitis and TB services, there were less testing facilities, less treatment also for other infectious diseases, not only for HIV. And there was also a disruption in harm reduction services and then opioid substitution therapy services. So I think that it's very important to try to intensify these prevention measures, at least in key populations, and to build, let's say, trust in, let's say, local strategies and in policymakers, because there is, even during this pandemic, we saw that we noticed there's mistrust in policy makers and in what was happening in the country.
And for you, Christiana, then would that trust issue, would that be the main barrier that we need to overcome now if we are to meet those needs?
It's one of them, but there are still a lot of barriers to overcome. And first of all, we don't have to forget that there is still a lot of stigma and discrimination, and it's a community stigma, self-stigma, and even healthcare providers stigma. And this is something that we have to be aware of. And there is also some barriers related to not only to the healthcare system, because we know that there are a lack of availability, sometimes lack of HIV testing, lack of viral load monitoring and prevention measures, but there are also some barriers related to patients, because there is a lack of education and awareness, and this means poor adherence. Sometimes patients experience also treatment fatigue, and there are also some substance abuse and alcohol abuse, psychiatric disorders. These are also some barriers, and also some social and economic determinants, because there are a lot of patients have a lack of health insurance. There are a lot of homeless. There is poverty, inequity, and these social determinants were anyway, in a way, exaggerated or in front during the COVID pandemic. And of course, there are the last also barriers related to policy, lack of funding, lack of long-term strategy, financial constraints. That there are still all of these barriers.
Thank you. We'll come back on that in our discussion later on, and we're going to hear from a policymaker now, so we'll also be able to get his response. Christiana, thank you for now. I look forward to welcoming you back shortly. Now let me turn to John Ryan, who, as I said, is Director of Public Health in the Commission's Directorate General for Health and Safety. John, thank you so much for joining us today. I mentioned those United Nations warnings in June this year that we risked not making the 2030 target set out in SDG 3. In terms of the EU, do you feel that within the European Union we are on track, that we're headed in the right direction, or what remaining challenges are there from your perspective?
Well, I think good afternoon, everybody. First of all, the 1990 treatment targets have set clear goals for 2020, and 2 of these targets have already been met. So I think we can also turn a positive spin to this as well as a negative one. The member states and the European Commission itself are still committed to reaching these targets. We know that 88%, for example, of all people living with HIV have been diagnosed. This still leaves, of course, a large number of people, which is renewed every year, who are undiagnosed. And I think we need to focus our attention on this group in particular. But 93% of all people diagnosed are receiving treatment, and over 90% of those diagnosed and on treatment have been virally suppressed. So from that point of view, we are making progress, but I agree that there is a need to keep a focus on HIV, and I'd like to go into that in more detail perhaps during the discussion later on.
Absolutely. And just in terms of the EU's role in this, so this is an area where the European Union has very limited powers. Health policy is a matter for member states, so it's done at member state level, but you do have a supportive, a coordinating role. How do you see the EU's role in addressing some of those issues that we will still need to tackle? And perhaps you could say 2 words. We've seen a lot of recent EU health initiatives, Health Union Package, the pharmaceutical strategy, number of initiatives. How do you see them contributing to addressing these issues?
Well, even though the European Union health policy is largely in the hands of member states, we do have a coordinating role. And I'd like to emphasize that we do have a system of surveillance in place, for example, which allows us to collect data on HIV infections in Europe, which gives us a real-time overview of the situation. That's managed through the European Centre for Disease Prevention and Control, which is our agency on communicable diseases. But we also have a system in place which allows us to financially assist projects in member states, both for the member states themselves, but also for the NGO community. And I'd like to emphasize that point. And we have seen since the COVID pandemic that the Commission has strongly reinforced the financial instruments which we have for health, including the EU for Health programme, which has a vastly increased financial envelope available to it. We also have the Horizon Europe research programme, which also has a very considerable budget, and will be important in setting the priorities for these 2 programmes, that we take account of communicable diseases and in particular HIV. And of course, other policies which we have and which we're developing, particularly in respect to pharmaceutical policy, will also play a contributing role to the control of HIV in the future.
Thank you. Lots to come back to in our discussion. And John, do stay with me. I'm going to ask Tamas and Christiana to join us again in a moment, but let's first have a look at how you answered that polling question. So I asked you to indicate the top 3 elements of the 5 we gave you, and a very, very clear result. In fact, I'm just looking down, more and more coming in already, but prioritizing prevention. A point that has already been made in our opening speeches, and Christiana talked about in particular, 68% of you. Stigma and discrimination, mentioned by Christiana, but very eloquently too by Tamas, that continuing problem, 64%. Support for patient communities and NGOs. So that's a question, how best to support them. One perhaps for our discussion. Figures moving around a little bit, but lower numbers for access to medicines and to diagnostics and viral load tests, but still over half of you. And scrolling down, investment in innovation, interesting. I mean, a key area from an industry perspective to play their part in combating this. It may be, I don't know, let's find out in the discussion whether people think the investment levels are already very good and therefore we don't need more. And that question, when it comes to access, I would like to talk to the panel about equality, equity of access, because we do see significant variations across the EU in access to treatment and services, and particularly to innovation. So lots to come back to in our discussion. But as I say, prioritizing prevention was really more clearly now 69%, and stigma and discrimination coming in after that. So thank you very much for that. Panel, please do come back and join me. Turn your cameras and your mics on. And Tamas, let me come to you as you're the first to appear back again. I hope Christiana, and there we are. Hello, and John's there as well. Tamas, in terms of what we need to do you believe that we need to do more of the same? Or do you think this is a moment when we need, going back to the title of this event, a shift in policy? We need to do something very different if we are to get there, notwithstanding those positive figures that John mentioned. To, as he said, there's still more to be done. Is it more of the same, more intensely done, or things done differently? Same question to you all, but Tamas first.
I think clearly we need to do this differently. I mean, it's not more of the same. And I think that the figures that you just showed from the poll are very much in line with what we feel in the patient communities as well. And let me reflect on this issue around innovation, that you were puzzled about why there's such a low priority assigned to innovation and new medicines, new treatment options. I think that we have the molecules. We have very solid, very reliable knowledge about what works and what doesn't work in the treatment of HIV now, and we've been repeating this for years actually. Now we need to put the molecules into people, and that includes prevention as well. I think prevention is tremendously important, and that's why we in the HIV community have done so much in order to spread HIV prevention, biomedical options, also psychosocial options, all sorts of modalities of prevention. That really needs to scale up now. So it's a public health issue. This should not be a financial or a political issue. It's a public health issue. HIV has become a preventable illness, so let's prevent it, because it's just much more efficient, and it makes a lot more sense to take out all the moral and political perspectives and considerations from this equation and treat it as it is, a public health issue. So if you can prevent a lifelong, expensive infection from spreading, then let's do it. It's that simple. And that, I think, really needs a change in how we approach this, because I think that our current structures are very rigidly concentrating on treatment or prevention. And it's very difficult to combine these two domains. So either you do prevention or you do treatment. Then there's, there was this, for years and years, we've been discussing this. Should HIV prevention be located at the HIV departments in the hospitals and clinics, or should it be with the GPs, or should it be somewhere else? Why is it so difficult? I mean, it seems to be so straightforward, and also the community can enhance this very reasonable demand for more support to the community. The community has done it very well, so let them do it. I mean, we know how to reach the people who need HIV prevention, because they are us. I mean, they are our friends, our fellows, peers. So, and that really requires a shift, because that means that as opposed to the current logic in healthcare, we really have to put the control into the hands of the patients in this case, the patients and the affected communities, because they know best where to go and how to speak to the population.
I'd like to come back on that point in a little while, if I might. But just in terms of this question, Christiana, for you, would you agree with Tamas that we really do need to do things differently? He pointed to a number of areas where he thinks significant changes need to be made, or is it more of the same?
Yes, I agree, and I think that it's very important to intensify this prevention methods and engaging community, at least in low and middle income countries and in Eastern European countries, because we are talking about the cascade of care, and we know that we have some 90s there. But if we look at the Eastern European country or even in other low-income countries, then we can see that we are far from the 90s. And if we are talking about even from my countries, there are still some break points in the cascade of care. So it's not really everything so well. And during this COVID pandemic, because, for example, I'm working in an HIV department, but now, since 1 year and 9 months, I am transformed in a COVID department. So there is a problem with, for example, hospitalizing patients with HIV that need us. Labs were repurposed for the PCR for SARS-CoV-2 and have less time for testing and for viral load or even for resistant testing. So there are some difficulties in this time. So we have to be careful not to lose what we have until now and what we gain, because during this time, even there was these measures, quarantine, social distancing, and other prevention methods reduced a lot of access to HIV.
Jenny, you seem to be also saying, you seem to also be saying, taking aside what has happened over the last 18 months because of COVID, that even what we said, protect and preserve what we had, but even do more. I mean, we need a change even from that.
Yes, and I think it's very important to engage community and to engage NGOs, and because there are a lot of people and social workers and people from NGOs that could be extremely helpful and are extremely helpful and know a lot of things. And
thank you very much.
Help. Yeah.
Thank you. John, you talked earlier a little bit about the sort of things you mentioned, the financing, you mentioned EU for Health, the program there, Horizon Europe, pharma strategy, and so on. Sounds that it's really intensifying of what we already have. What is your reaction to the suggestion that no, we need to do things differently now?
Yeah, well, there are 2 points I'd like to make. First of all, in reaction to what Tamas just said, I'm disappointed with the interface between the NGO, patient, health professional community and what we're doing on HIV in Europe. We did have a specific group which was dealing with HIV, TB and hepatitis, and this was put on a virtual platform. In fact, we anticipated the COVID outbreak in that sense, because now everybody is on Zoom. We're on Zoom. But I mean, there was a great reluctance to engage. At the time, I was told that people had to physically meet in order to discuss things. We've seen now that it's a little bit different. I'd like to relaunch and reinforce and re-engage with the civil society community much more actively, because I completely agree with Tamas that if we don't have this link with the civil society community, with health professionals, with patient groups, then we're really driving in the dark. So that's the first point I'd like to make. And the door is open there in order to discuss with you how we can make that a reality. I've just been through a year of the cancer plan, the Europe Beating Cancer Plan, which is one of the Commission's flagship initiatives. And we have a specific group of stakeholders looking at every aspect and following us and accompanying us on every aspect of the cancer plan. And I'd really be happy to re-engage with civil society and patient groups in order that they could advise us on where we best need to put the focus. The second point is on prevention, and I agree with Christina that there are many different determinants of health which can influence prevention. And I think we need to take an approach which is more horizontal or more open than we did in the past. Because for instance, in certain communities, there are issues around alcohol or drug abuse, which can influence how your prevention messages are conveyed. And this brings me to another point that Christina mentioned. Sorry for picking up your ideas, which is the issue of stigma, because I don't think we've got rid of stigma. I think stigma is still there. And the more you look at these other factors, whether it's migration, whether it's residency rights, whether it's social status, whether it's the use of drugs, then you're mixing all sorts of issues, which makes it even more complicated. So I really think we need to look again at prevention and try and develop some strategies. And I have an idea there, which I'd like to throw out for you to consider. In the field of non-communicable diseases, we've set up a group with member states called the Steering Group on Prevention and Promotion. This is already in operation for 3 years now, or maybe even 4. And we really try and identify interventions which are evaluated and shown to have an effect. And then the European Union finances those interventions in the member states where they're needed. So we're not looking to finance something where it's not needed. You know, coming back to the inequalities point, it's the countries who actually have a need, or the groups where there is a need for an intervention, where we're trying to have tailor-made interventions and then finance those. So this is one of the ideas the Commission is looking at the moment, whether we couldn't, for example, take some communicable disease topics such as HIV, vaccination, antimicrobial resistance, and so on, and pick out specific interventions. So not having a grand strategy or a paper plan, but an actual practical intervention which we could actually engage with the actors on the ground and actually use the financial instruments where they're most needed.
Thank you very much. And Tamas, I'd like to give you a chance to react to that, both to this broader point about, John was talking about relaunching, reinforcing, re-engaging. We saw from our audience very high figures on supporting patient communities. And you talked at the beginning about putting control in the hands of the patients and the affected communities. This is obviously part of that equation. So your reaction to what said there, but also what other ways do we need to make sure that we put patients and affected communities in control?
So I couldn't agree more with John, especially because I used to chair that particular body for a couple of years, or co-chair the Civil Society Forum. And it was, yes, those were difficult years, but very successful at the same time. So I think it makes perfect sense we have a tradition, we have a working scheme or structure. We should use it. And I think that in terms of putting control, isn't everybody promoting now recently, increased self-care, health literacy, self-awareness, holistic care? These are all buzzwords, but actually this is something that has been there as a living tradition in the HIV world. So we can build on that. We can build on that tradition and then also branch out from there into other disease areas. Like John mentioned the cancer mission of the European Union, and in fact, many of the patient representatives who are there have been working with the HIV community and learning from the example of what we did before. And so it would be so sad if that tradition simply vanished now when we've been doing this before. So it's not like we have to reinvent this, but it's this knowledge is already there, and this knowledge is there in the patient community as well. And so that's how we could all leverage on that existing tradition and body of experience and knowledge. And it's in line with all the other initiatives in healthcare that are ongoing.
Thank you. Just on the issue of stigmatization, a question from our audience referred to the stigmatization that still prevails strongly in the area of HIV, despite previous approaches to it, including in the policy space. The questioner asks, what can be done to finally lessen the stigma, and how can communities, which is why I'm bringing this up now, be meaningfully brought on board in these efforts? Christiana, both you and Tamas spoke about this, and John just there underlining it's not gone away. What can we do?
What can we do? I think education is very important, and we start with this education with our medical students, because it's important to avoid healthcare providers' stigma. because we experienced this, because I, for example, I was working with a pediatric cohort of HIV for many years, and we experienced when we had problems with any other specialties, we had problems in having another, help from other specialties, surgical or other kind of specialties, and we had to talk a lot to explain, that is this is a disease. We have to. They are treated. They are not. They cannot transmit if they are undetectable. So a lot of things that we have to talk with doctors that talk about the community. So we have to start with educating our students.
Absolutely. John, you mentioned it. Do you see a role for policymakers in addressing this?
Not necessarily for policymakers. I wanted to draw your attention to the European Centre for Disease Prevention and Control. They are launching 2 novel projects, which will be launched already in 2022, at the beginning of 2022. And the first is a survey in the community of people living with HIV in order to try and identify elements of stigma which might be obvious or may not be obvious. And secondly, to go back to Christina's thing, the second survey will be among clinicians who are specializing in HIV in order to try and identify in the healthcare setting what issues they have identified. On the issue of stigma in the cancer plan, we identified the right to be forgotten as a big issue. The right to be forgotten for cancer patients. More and more patients are surviving cancers. And this is posing their own problems because, of course, it's good news if people survive their cancers, but then they have to live with this throughout their life. And one of the issues we've come across is the right to be forgotten, but also the implications for insurance, for example, or for bank loans, things like that, which also contribute to stigma, because it's stigma in your normal life when you're living as a HIV patient with undetectable virus. And you still have to explain to your bank manager what that means, or you have to explain to your insurance agent what
Absolutely.
that means. These are practical things where I think we could perhaps make some progress. And there are links to be made there with other policies, as Thomas was saying, with the cancer plan. If we are doing something for the right to be forgotten and for stigma in cancer, why wouldn't we do it for HIV? And that's where I think we can work with the stakeholder communities, with the patient groups, with health professionals, in order to identify where exactly we need to, and where would the biggest value added be for a European approach, shall we say.
Thank you. Tamas, a brief one, if you would, in terms of addressing the stigma issue and what we need to do.
I think I agree with Christiana that it's education. We need more very conscious, targeted education, and trying to overcome political barriers here, which requires central coordination. I mean, this really requires the leverage that the European Union has, even if it sometimes may be challenging, reaching out to countries with educational plans and programs and suggestions that are maybe not that receptive to that, but I don't see any other way around this. It's spreading reliable information.
Yeah. Could I just ask another question? And you talked being far from the 90s in some areas, and you talked about the cascade of care. In terms of addressing inequalities in access to care, treatments at country level, to innovation, what do you think needs to be done? What do we know about what works, and the role that John and his colleagues can play, the EU level can play, in helping to address those inequalities?
I think diagnosis and treatment has to be free for everyone. Doesn't matter if it's a person from a key population, from vulnerable groups, from immigrants, because there is still a problem, for example, for people that have no health insurance, that are homeless, that are or living in shelters, that are immigrants. So I don't we have to remove all these barriers, all these social barriers. And of course, we have to work with this, let's say, community level, to overcome community level barriers, for example, to overcome lack of social support, this feeling of isolation or social rejection, of course, this stigmatizing attitudes and toward HIV and discrimination. So this is the way that we have to come forward and to try to overcome this.
Thank you. Other thoughts in terms of this inequalities issue, and John, a role for you and for the Commission in this?
Yes, I think bringing different 2 points I'd like to make. First of all, in terms of the patient experience, and encouraging people to become tested, and then to follow on their treatment and to regularly go through the health system. I think it's very important to take on board one of the ideas which we've developed in other policy areas, which is the patient pathway. Patient pathway, the importance of taking care of your health overall and not just focusing on HIV, because smoking, for example, is a major determinant in HIV, and it's really important as well that it's not just a question of taking a pill a day, it's a question of having a healthy lifestyle. So how do we have a patient pathway which allows patients to take care of their own health more globally, I would say. So this issue is, I think, a challenge in some health systems, that the focus is just on treating the disease and keeping the disease under control, whereas what's really needed is a wider approach to a healthy lifestyle as well. And the second point I would like to make is in respect of innovation, which Thomas was talking about earlier on. And I think there are possibilities there in the pharmaceutical policy notably, but also in the research program, in order to develop ideas about bringing new medicines to the patient more quickly. And finally, I would mention the point about the necessity to really consider how we take advantage of the situation we're in, because we're in a most unusual situation at the moment, that we have a focus on health. COVID hasn't been all bad from the point of view that it has brought new financial resources to us. And I'm really anxious to engage with the community in order to see how we can best use the opportunities we have, identifying the policy initiatives that are needed, identifying the interventions which are needed, and then using the resources of the European Union. And this is not only a question for the European 27 member states, but it's a wider issue. How do we make sure that, for example, to help our neighboring countries, the enlargement countries, and more widely, countries in Africa, for instance, to develop their capacity? I don't want to throw the debate completely open, but it does seem to me that there is this challenge as well, not only within Europe, but also internationally. Yeah,
absolutely. Just linking to your point about other health issues and so on, a question from Boris Zais from the audience saying, should we give more attention to the chemsex phenomenon, that being the phenomenon of using drugs as part of your sex life? He says it raises health issues and seems to remain under the radar of public health institutions. We've supported efforts at community level to shed light on this, address related issues. Tamas, please do react to what has been said in terms of inequalities of access, but also on that point as well, this broader.
Yeah, let me start with the chemsex issue, because that's something that's very close to my heart, and I was one of the first people to talk about this at the WHO and at ECDC many years ago, and there was and still is some degree of skepticism around whether this is a valid topic at all. But I believe that chemsex is a symptom. It is a symptom of an underlying cause, and that underlying cause is that some populations, which are then also more exposed to HIV and other communicable diseases, notably, especially hepatitis C, are in a very poor psychosocial state. And so that needs to be remedied in order to be able to overcome the chemsex challenge. So again, it requires information, it requires proper research. It's very difficult to research this area, and research is not cheap. So that again requires investment. So there, I think I mean, that's where the resources could be used very well and very effectively, because it's still cheaper than other biomedical interventions. And I think that okay, I stop here and then let the others speak, and then I come back to your other question.
But also on this point about inequalities of access to innovative treatments and so on. What do you believe needs to be done to address that point?
Well, you know, it's a political issue, isn't it? So I think that what we really need to do here, because what we do in the community make pressure, that's been done and that's continuously being done. I think it's again a political decision that it's not a moral issue, it's a public health issue. And it's also, it's not expensive anymore. HIV is not expensive anymore. It's not like you pay you know, that it costs an arm and a leg to keep someone alive who lives with HIV, or that prevention would be expensive. It's not. So it really is just a decision whether you want to do it. And I mean, what else can we, I mean, patients here say, then repeat again and again that it's worth it. You should take this decision. It's not about what kind of life you live. It's not about whether you're a good or a bad person. It's about keeping your people alive. It's a basic political decision.
Thank you very much indeed. Christiana, did you want to come back on that? Yes, I think that we as physicians can have an important role here because, for example, we had applied for a European grant, and we treated all our HIV, HCV co-infected injecting drug users without, and they didn't need anything to have insurance or other documents. So they could be from the streets or area. And we treated them with the support of this grant. And we had excellent results and even good adherence with this. And we were, I think, one of the first centers who treated this vulnerable group. And I think that we can move on also in this direction if we have no social support or something, governmental support, policy support. We can do something. We can fight for our patients too. And I think it's also very important that in our centers, in our hospital, to have, let's say, it's maybe a word, but it's not a simple word, that this patient-centered care, because we have to have a multidisciplinary team. We have to have social workers, psychologists. We treat also TB. We treat also hepatitis in our center. So sexually transmitted diseases. So our patients don't have to move in different centers, different hospitals, So if we bring them all there, we help them. If we can have also this opioid substitution therapy in the same center, then it will be extremely useful for our patients. Thank you, John. And just picking up, we have a question from the audience picking up on what you were talking about in relation to the rest of the world. The question says, like other infectious diseases, the HIV situation in the EU is increasingly influenced by global trends. And as mentioned by the panelists, migrants and refugees are disproportionately at risk of vulnerability for HIV. How can we achieve a truly European-wide and global approach to HIV prevention and control?
I think we probably need to take what we're doing domestically in Europe, make sure it's the best practice, and then try and use that best practice to help other parts of the world which need our help. I was referring to the enlargement countries, to the neighborhood countries. We have many countries on our borders who have major issues with HIV. They have even more challenging situations than we have in some of our member states. And then when you throw the net even wider and more globally, you do need to work with international organizations. We are supporting, for example, the African CDC. And I think it would be important that issues like HIV, as with COVID, are properly prioritized in that work.
Absolutely. Can I just pick up on a point you made? You were talking about this idea that you're already doing with non-communicable diseases, this steering group on prevention issues. And I just wanted to come back to a question I raised right at the beginning about, we talked about some of the successes of the last 40 years. We've also talked about some of the remaining challenges. John, and then I will come to you after that, Tamas. But John, in terms of the lessons we can learn from the HIV experience and the extent to which HIV and the approach can act as a model for other disease areas. Do you think there are things we can take from this and that it can, or do you feel some of the challenges we face with it mean there's a limit to the lessons we can learn from it? You pointed to the successes. What can we take from that for other areas?
Well, I think what strikes me about the approach to HIV is the complexity of the issue, because you imagine that the situation is under control because you have a treatment, and then you discover that we have a large number of new infections every year. I'm just looking at my figures here, but the infection rates are still continuing. We have 785,000 people living with HIV in the European Union at the moment, and we have 25,000 new cases per year. Now, this is not something we can continue to live with. I mean, this really is a political issue as well as anything else. And I think when there is a communicable disease, which will then turn into a chronic disease if treated, this is a major challenge. It's still a major challenge for our member states. And as Christina said, it's worse in some member states than in others. So therefore, we've got to target those member states which are at the bottom of the pile and try and target our help to those countries as a priority.
Absolutely. Tamas, you wanted to come in to react to something John said earlier, but also on this question, if you would, of the degree to which HIV can be a model.
I think that what I wanted to point out when John was speaking, that actually learning also goes the other way, because in the HIV community, we've learned a lot about what some community organizations in Africa have been doing, for example, in terms of reaching groups of people that are hard to reach, so to say, but in the literal sense. So they live in remote areas in the countryside. There's very little traffic or transport possibilities, or they don't have the means to get to the nearest clinic. So we've learned a lot about how to bring treatment and information and care to the people, instead of expecting people to come to the care facilities and to receive treatment or testing. So, and also how to build communities, how to talk to people who are perhaps illiterate. So there are some very good models for how you can reach hard to reach populations. If you look, for example, in Africa, I think that yes, I mean, HIV definitely is a model. HIV is a model for how you can work together with communities. HIV is a model for patient organizations and patient leaders, patient experts, for what you can achieve if you really lean into it and if you really try to organize your work. That you can change policies so that it makes sense to continue with the fight, because you can achieve change and you can build structures that remain functional over decades. Maybe they change, maybe the priorities shift, but these structures have been functional. So I think that's a very good model to see that it actually, there's a way forward. We just have to fine-tune this to the different disease areas.
And you've answered in answer to that, you've answered also another question from our audience about how to better engage with marginalized communities in care development and so on. You really have provided a model, as you say, for reaching out, which can be used. Christiana, do you believe HIV is a model that is replicable, is usable for other diseases?
Yes, I think it's a model, even for I think it was a model even for hepatitis, treatment, and I want to come back on the role of the community, because I think in the HIV pandemic, the role of community and of HIV advocacy was extremely important and moved further research, and everything was innovative in HIV was a little bit pushed by the role and by what the community was doing, asking. And this was an important thing that moved even research in HIV or treatment and everything. So this is the role of the community. It has to be is a model also for other diseases, the role of HIV advocacy. So this is something that I have to highlight, because I saw this since so many years, since I work in HIV, since more than 25 years. And this was what I saw in these people, what great things they were doing and achieving by their roles.
Thank you very much. We are almost out of time, and I want to put each of you, if I might, a little bit on the spot here, because we've talked about a whole range of issues over the last hour that need to be addressed, from those issues of stigmatization that we started through to inequalities in access to care, some of the big challenges moving forward, but also that shift in policy, which you've said we need, irrespective of what happened in the last 18 months, if we're going to get there by 2030. For each of you, and on this last question, I'll start with Christiana first, then I'll go to Tamas, and I'll give John the last word. If I asked you to identify, it's a very unfair question, I know, but it's similar to what we asked our audience to do at the beginning. We gave them 3 elements they could pick. I'm going to ask you to choose one. Your most important priority, Christiana, key next step, if we are really to accelerate progress towards halting the burden of this epidemic. 1 minute each. Christiana first, then Tamas, then John.
I have to come back to prevention.
Yeah.
I think that even the audience mentioned this, and I think prevention now is the most important fact, and that's work. Yes.
Yes, Tamas.
Work with the community. Work with the community of people living with HIV and of people affected or at risk of HIV, and take them seriously, because there's real knowledge, real skills, real input to be had. You just have to work with them, or with us rather, and then change will happen, because we've already made change, so we know how it goes, and we're not afraid of work. So trust the community.
And that working together, bringing everyone together who needs to be round the table in order to address these issues, these very complex issues, as you indicated right at the beginning. John, for you, your most important priority or our key next step?
Well, I think key next step is to renew and relaunch our work on HIV, really to look at what's been done in the past, but not to look backwards, look forwards and see, and don't forget we have a new generation of people coming into clinics, coming into their sexual life, coming into the educational system every year. And it's really important that we take this on board and try and come up with new approaches, new strategies, whether it's for prevention or for treatment or for survivorship. For any of these areas, we really need to look forward and try to have a long-term vision for HIV in Europe.
Thank you very much indeed. And panel, thank you for a fabulous discussion. We didn't have very long, but we covered an enormous amount of ground, and we're very grateful to you. I should just mention before we go, ladies and gentlemen, there is another session coming up immediately after this one. Head over to the NLO Exchange, join the Nobody Left Outside Voices network discussion about the needs of marginalized communities in HIV care and beyond. So very much linked to where we ended our discussion today. Thank you, panel, for a terrific discussion. Thank you for joining us this afternoon, and goodbye.